Good evening, everyone, and welcome to the National Pancreas Foundation's virtual education webinar on healthy lifestyle and nutrition. I am Tricia O'Neill, the National Director of Chapter Development for NPF. The National Pancreas Foundation's mission is to provide hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. To learn more about our programs, please find us at pancreasfoundation.org and be sure to follow us on Twitter, Facebook, and Instagram. Some of our featured programs include the animated Pancreas Patient, the NFP Cookbook and Pocket Guide, which is offered in hard copy as well as a free download, our National Patient Registry, and our state chapters that support education, fundraising, and patient support. Our success depends on the support of many individuals and organizations, and you can help make a difference by joining NPF as a volunteer, making a donation, or sharing your own personal story. During tonight's presentation, please submit your questions in the Q&A section of the platform, and we will address those at the end of the session. Our topic this evening is healthy lifestyle and nutrition, moderated by Dr. DK. I'd like to thank Dr. DK for her continued support to NPF and the programs, and express gratitude to all of our expert presenters from the Children's Hospital of Philadelphia and the University of Pittsburgh Medical Center, and to our patient speakers. Dr. DK is an assistant professor of pediatrics, Division of Pediatric Gastroenterology, Hepatology, and Nutrition at the University of Alabama at Birmingham Children's Hospital of Alabama. She is also a member of the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition Pancreas Committee. Dr. DK developed a passion to care for and advocate for children with pancreatitis during her gastroenterology fellowship at the University of Iowa. She has built a multidisciplinary pancreas program at the Children's Hospital in Omaha. Dr. DK is currently helping to build a multidisciplinary pancreas program at Children's of Alabama, UAB. She has served as NPF's chapter medical director for chapters in Nebraska and in Alabama. She understands the importance of the management of attacks and pain in pancreatitis via a wholesome approach, and has co-authored reviews on multidisciplinary approach to care in children with acute recurrent pancreatitis and chronic pancreatitis, and nutrition management and pancreatitis in children. I want to thank you all for joining us for this very informative session, and would like to welcome Dr. DK.
Thank you, Ms. Trish, for that kind introduction. So our first speaker is our patient speaker, Mackenzie Tester. She's a 25-year-old NYU graduate who has experienced chronic pancreatitis for the most part of her life, beginning from freshman of high school. Therefore, she can relate to both pediatric and adult pancreatitis. She's now a fitness coach and will be sharing a little about how she's been able to use a healthy lifestyle to control flares or attacks of pancreatitis. Please join me in welcoming Mackenzie Tester. And thank you, Mackenzie, for joining us today.
Awesome. Hi, everyone. Thank you so much, Dr. DK. And thank you, NPF, for including me on tonight's webinar. Again, I'm Mackenzie Testa. I'm super excited to be here to share a bit more about my experience with chronic pancreatitis and how that's really shaped a lot of different aspects of my life. And also very excited to hear from and learn from the rest of the panel tonight. So let me share my screen with you all. Let's see. All right, included just some photos of myself to highlight as I give some background on me. So yeah, for some background, I grew up in Potomac, Maryland. I come from a big family. I'm one of five, and grew up in a very active household. So my parents had us in sports at a very young age. So, you know, staying active and healthy really became second nature to me at a pretty young age, which I'm, of course, very grateful for. I'm a singer and dancer, as Dr. DK mentioned. So I've been pursuing performing ever since I was little. That's a big focal point of my life as well. And in regards to my experience with pancreatitis, so it was around age 14 that I had my first episode of pancreatitis. This was the first time I had been hospitalized for it. And at that age, I remember vividly just how scary it was to actually be diagnosed with the disease. Of course, at that age, I knew nothing about it. I did not know what that meant, what that was. So it was very scary to initially, get that diagnosis. And from there, we found out shortly after that my form of pancreatitis is genetic. So it would likely be something that I would deal with throughout my life. And from that first episode forward, I definitely became much more aware of, what I was putting into my body, how I was treating my body overall. And it really forced me to kind of take a look at my lifestyle habits at a much younger age than I probably would have otherwise. So that was the early part of my high school experience. Fast forward to the later half of high school and into my time at NYU, I did have several more episodes where I was hospitalized for pancreatitis. So it became, pretty clear that if I, wanted to live without pain, if I wanted to take care of my body properly, I really had to take this seriously. And it was also around this time in college that there started to be a lot of pressure to experiment with alcohol socially. And not a ton of people at my age at that time were sort of hyper aware of their diet by any means as well. So it kind of forced me to become comfortable in being uncomfortable in many social situations in a sense. So at this point, I really became pretty aware of things that triggered an episode of pancreatitis for me, which personally is alcohol, of course, but it's also things like highly fried or fatty foods. So I was able to start to adjust my diet accordingly, started eating predominantly whole, as minimally processed food as possible. And I also really tried to become okay going out in social situations without drinking, which again, during college was pretty difficult. But I'm pretty grateful now to be as comfortable going out in social situations without drinking. I think it was a blessing in disguise. So later half of college for me, I started to look at my health from a more holistic perspective. I really wanted to identify ways that I could assist my body on a daily basis alongside some of these habits I'd formed to, as best I can avoid another pancreatic attack. So my junior year of college, I started teaching fitness classes at a studio called Dance Body. I still teach here to this day, dance, cardio, sculpt-based classes in New York City. And this job has been really such an incredible outlet for me to fuse my passions of fitness and dance. But I also believe this has played a really big part in keeping my pancreatitis at bay. In my eyes, I kind of see health having many pillars. And I know for me, taking care of myself from many angles, not just one, I believe is what's helped me keep my pancreatitis in check throughout the last handful of years. So, while proper diet, low alcohol consumption are of course important, I also believe that things like fitness, meditation, and proper sleep are also a crucial part of overall wellness, especially when, you suffer from a chronic disease. So alongside teaching fitness classes, I also started doing things like meditating regularly, becoming more cognizant of the amount of sleep that I was getting every night. So just overall looking at my health from a more holistic lens. And of course, I'm definitely not perfectly in line in each of these areas by any means. There's definitely give and take, but I think when I focus on majority of them majority of the time, it's allowed me to really live a bit more flexibly. So when one area isn't as strong, the others tend to sort of even it out in a sense. So since, I've really honed into this holistic sort of approach to my health and well-being, knock on wood, I haven't suffered from a pancreatic attack within the last 5 or 6 years or so. So very grateful for that. That said, I also understand everyone's experience with pancreatitis specifically looks a bit different. I just know for me that, living with this idea that you can really assist your body in a multitude of ways rather than just kind of a one or two-sided approach, this has really been helpful in my experience so far. So yeah, in a nutshell, that's a bit about me, about my experience with pancreatitis in relation to my overall, health and wellness. Again, thank you guys so much for having me tonight. And I'm also really excited to hear from the rest of the panel.
Thank you so much, Mackenzie, for sharing your story with us. And we'll take all questions at the end. I know people have a lot of questions and people would like to hear more about your experience. We'll take more questions and comments at the end. So now I would like to introduce our second speaker. I'm honored to introduce Dr. Mascarenas. She's a professor of pediatrics and a pediatric gastroenterologist in the Division of Gastroenterology, Hepatology, and Nutrition at the Children's Hospital of Philadelphia, CHOP. She also serves as the section chief of nutrition in that same division, the medical director of the Clinical Nutrition Department, and director of the Integrative Health Program. She's one of the very few pediatricians who is board certified in pediatrics, in nutrition, in pediatric gastroenterology, and board eligible in integrative medicine. In addition to her extensive medical training, she also has additional training in pediatric massage and clinical hypnosis. She single-handedly developed the most comprehensive integrative health program at the Children's Hospital of Philadelphia, which is considered to be the model in the field nationally. She's widely published, and she has the latest publication that has been getting great reviews from a lot of both providers and dietitians, called Anti-Inflammatory Family Cookbook. So please join me in welcoming Dr. Mascarenas. She'll review the literature to support the role of an integrative approach to pancreatitis, specifically with respect to pain management. Thank you. Dr. Mascarenas, I'll share your screen. So give me 1 second.
Okay. Thank you so much, Dr. DK, for such a wonderful introduction, and welcome everyone. It is truly a pleasure to be with all of you. I was given the honor of presenting to you about the integrative approaches to pancreatitis. And when I reviewed the literature, there wasn't very much in pediatrics, and there wasn't very much in adult medicine. So I'm going to share with you the literature that is available. And if we have time, we will also do some experiential work as well. Okay. Next slide. So we are going to talk today about what is integrative medicine. We're going to learn about the evidence to support the use of yoga, massage, and acupuncture. And I threw some mindfulness in there as well. And we're going to practice some stress relief techniques if we have time. Next slide. I have no disclosures relevant to this topic. So what is integrative health? Integrative health is really relationship-centered care that focuses on the whole person, is informed by evidence, and makes use of all appropriate therapeutic approaches, healthcare professionals and disciplines to achieve optimal health and healing. And so it's really looking at the whole patient, not just as pancreatitis, not just at who you are. It's like the whole you. So when we see patients and we address things with an integrative approach, we're looking not just at what disease state they have right now, but we're looking at everything: movement, exercise, nutrition, sleep hygiene, physical environment, relationships, growth, spirituality, mind-body connection, because all these things impact on the disease process. All these things will impact on how well you cope and your quality of life, as we've heard from the first speaker. So it's very important to look at the whole person and not just at one specific part. So the focus is really on holistic care. Next slide. And so we know that we have patients who have disease, but really we want to move them from disease to the absence of disease to full health, or to a place where their quality of life and their level of functioning is good. Next slide. So the National Center for Complementary Integrative Medicine, which is a branch of the National Institutes of Health, defines integrative medicine by actually explaining the terms complementary, alternative, and integrative. So complementary medicine means when you use a non-stream main practice, which is used with conventional medicine, it is called complementary. Next slide. When you use a non-mainstream practice in place of conventional medicine, it is considered alternative. And next slide. And when you use integrative medicine, it's bringing together complementary and conventional medicines in a coordinated way and using the evidence. So I put this little cartoon up of or screenshot of the NCCIH because it is a very good website where you can get very accurate information, where they review the literature, they update things every couple years. And so it's a wealth of information with regards to herb supplements, all the mind-body modalities, etc. Next slide. So these are the components of integrative health. So there are three main categories: natural products, other healing systems, and mind-body practices. Next slide. So under natural products, we have herbs, vitamins and minerals, probiotics, nutrition, and dietary therapies. And we're going to hear about dietary therapies later in this webinar. Next slide. Under mind-body therapies, there's yoga, mindfulness, massage, acupuncture. There are relaxation techniques like breath work, guided imagery, progressive muscle relaxation. There's hypnotherapy or clinical hypnosis, healing touch, and Reiki. And today we will talk about the literature about yoga, mindfulness, massage, and acupuncture. And if we have time, I'm going to give you the experience of breath work, some meditation, and progressive muscle relaxation. Next slide. The other healing systems that have been used or come under this umbrella are traditional healers, Ayurveda, traditional Chinese medicine, homeopathy, and naturopathy. Next slide. So how can integrative health help with pancreatitis? This is a very summary slide. So we know that there are genetic factors, metabolic factors, lifestyle factors, trauma, cancer, medications, environment that can all contribute to someone having pancreatitis. Well, integrative measures are the mind-body modalities that can help with the stress, and then also nutritional diet therapy that can help with the pancreatitis during an acute episode, and then with chronic pancreatitis in the chronic phase as well. Next slide. So one other thing I wanted to mention was chronic pain. And we know that chronic pain is a big feature in pancreatitis, whether it's acute pancreatitis or chronic pancreatitis. And we know that integrative or complementary measures can be pretty effective for chronic pain. And I put this screenshot just for you to see that acupuncture, hypnosis, massage, mindfulness, meditation, spinal manipulation, music-based intervention, Tai Chi, Qigong, yoga may all help to various levels with chronic pain conditions. So these are tools that are available. Now, some of these tools, by and large, they're safe, but you need to follow with or see a experienced licensed provider who has expertise in these areas. Next slide. So let's talk first about acupuncture. So practitioners, what is acupuncture? Acupuncture is the field where practitioners insert fine needles into the skin, and there's an example of that there to treat health problems. This has been available in China for more than 2,500 years. And the basic principle is we are all beings of energy, and similar to us having veins and arteries and lymphatics that take the flow of blood to and from the heart and lymph flow back to the venous system, you have these channels of energy. And if you put a needle or pressure in these channels, you can correct the flow, undo blockages. And we never had a good idea of exactly what this was, but more recently, they've actually found these channels in the interstitial spaces of the body. So with very sophisticated techniques, they're able to actually to prove that, yes, there are energy channels and we need to do more research to define them. And there is very good evidence to say that acupuncture is very effective for pain, back, joint, neck pain, postoperative pain, breast cancer pain, and headaches, as well as nausea. And sometimes you can actually stimulate the needles with a little bit of small electrical currents, and that's called electroacupuncture. Next slide. So what is the evidence on acupuncture and pancreatitis? So in one paper from Joel in Pancreas, they had decrease in pain scores, but the effect lasted 1 week. And if you go to an acupuncturist, you know that they usually prescribe a series of 6 to 8 weeks. And the first few weeks, it might be even twice a week, again, so that the effect lasts more than a few days. And in this study, the effect lasted just 1 week. Then there are 3 meta-analyses, mainly from China, where they've looked at all the studies that were done in acupuncture. And when they take acupuncture plus routine therapy, so that's standard medical or conventional therapy, and they compare that with routine therapy alone, they found that acupuncture, there was improved length of stay and sooner resumption of eating and recovery. In another study, they also saw that acupuncture combined with routine therapy helped with relieving abdominal pain and distension in acute pancreatitis. And then the last study actually looked at something called parasympathetic tone. So let me pause and explain what that is. So we have our autonomic nervous system, which is part of the nervous system that is not under our control. And there's the sympathetic part and the parasympathetic part. The sympathetic part is the one that gets all revved up when we're stressed. So I'm sure all of you can relate when I tell you, when you're stressed, your heart rate goes up, your blood pressure goes up, you sweat, you might want to go to the bathroom, to have diarrhea, etc. So it's this flight or fight response. The parasympathetic is the calming side. And so both these nervous systems, both these parts of the nervous system need to be in balance. So when we're stressed, the sympathetic tone is increased and the parasympathetic tone is decreased. And what acupuncture does is it increases the parasympathetic tone and so may improve physical well-being. Next slide. Moving on to yoga now. So yoga originated in India and really it consists of a blend of physical movement, poses, breath work, meditation, and mindfulness. And I think it's a wonderful, wonderful practice or mind-body modality. My mother practiced yoga till she was 90 years old and she broke a hip and she couldn't do it anymore. But you can do yoga sitting down, lying down. You can do very, very sweaty yoga, as I say, or hatha yoga, where you're working up a sweat. But yoga is more than physical. It's really a whole thing of mindfulness and meditation and poses. And each pose, actually, what you're doing with yoga, you're twisting muscles, but you're also twisting those energy channels. And so similar to traditional Chinese medicine, in Ayurveda, our body consists of these energy channels and they have similar pressure points that acupuncture has. So a lot of similarity in all these ancient medical systems. So yoga typically in the modern world is used for well-being, fitness, to control stress, and to help manage or prevent health problems. But there's nice supportive evidence in children that it helps with inattention, hyperactivity, anxiety, and in adults with stress, balance, allows people to comply better with healthy diets, physical activity, smoking cessation, weight control, fibromyalgia, low back pain, neck pain, headache, arthritis, cancer, multiple sclerosis, chronic obstructive pulmonary disease, asthma, diabetes, menopausal sleep. So have I sold you all on yoga when it does so much? But I think that yoga is really, it's not something that you do and you stop, it's a way of life. And I think however much you do in whatever you do, whether it's the physical movements, the poses, the breath work, the meditation and mindfulness, it's a lifelong practice that will help you and you'll be able to build on it as time goes. Next slide. So in yoga, there really is one researcher who did work some time ago, and there have been no recent studies. And this researcher from the UK actually looked at 60 subjects, so 30 subjects and 30 controls. They had yoga sessions twice a week for 12 weeks. They were 1 hour long. They were in the early morning. They went there before breakfast. It was in the park, so again, beautiful surroundings. It was 15 minutes of meditation, followed by diaphragmatic breathing, some mindfulness stretches and poses. And the whole routine was designed to help alleviate pancreatitis and pain. And they found in this study improvement in pain and about 62% reduction in pain, improvement in quality of life, decreased stress, mood improved, alcohol dependence decreased, appetite improved, and weight gain improved. And when they looked at the medications that were needed on an as-needed basis, there was a 36% decrease in them. So I think you all know what they are. If you have pain, you take a medication. If nausea, you take a medication. So that decreased by a third, which is, I think, pretty remarkable. But again, one study, small study, and we can't extrapolate that to all patients, but very, very promising. And if you look at those two tables, table 3 and table 4 on the right-hand side, if you look at the yoga group, you can see that from 0, which is baseline when they started, to 12 weeks, which is after 12 weeks, all those numbers go down. And I'll read through them: anxiety, depression, anger, vigor, fatigue, and confusion, everything improved. And then when you look at table 4 for another measure of the SOCI score, you can again see that again those numbers in the yoga group went down from week 0 to week 12, whereas in the control group they stayed pretty much the same. So depression, anxiety, fear, emotional irritability, and then total stress scores went from 92.4 down to 59.7. So a nice decrease. But as I said, one study, but a very promising study. Next slide. If you can hear my barking dog, I apologize. So with regards to massage is basically the manipulation of soft tissues of the body, and it's been practiced for centuries. It may relieve several kinds of pain, specifically low back pain, neck, shoulder pain, knee osteoarthritis, headaches, but the evidence is not very strong, and it may provide only short-term relief. It's also been used for help. It's helpful in anxiety, depression, in patients with fibromyalgia, cancer, HIV, and AIDS. And in premature infants, we've known that massage can actually help babies gain weight, though there's not such great evidence for full term. Unfortunately, there were no studies on massage and pancreatitis, so clearly an area that we should start doing some research. But anecdotally, I can tell you from patients who've received massage in the hospital, they uniformly all love it, the ones who agree to having it. Some people don't like to be touched, but the children who like having massage uniformly say that it helps them either relax or helps them with their pain. And oftentimes they'll fall into a sleep and the pain episode will be broken. Next slide. So I wanted to throw this study in, again, a very small study, but I mentioned to you that mindfulness is part of yoga. And so this was a telephone-based mindfulness study for patients with chronic pancreatitis. So 10 subjects, 5 controls. It was telephone mindfulness sessions daily for 1 month. They could either opt in for the 2-minute session, the 10-minute session, or the 30-minute session. There was 67% compliance, so people stuck with it. But the shorter sessions were used more often. And what they found was that when they looked at some measures of mental levels or anxiety, mental scores, things were better in the patients who got the mindfulness. And it didn't matter, even the 2-minute sessions were effective. Next slide. For pediatric patients, however, and we did a review of this, there've been no studies that have shown integrative approaches that have been shown to be helpful. So that's why the child is still crying. We still need to provide the evidence to support these therapies in pediatric patients. Next slide. I'm going to ask Dr. DK if I have time to do a few of these sessions, or if we should skip to the last slide. I don't want to run over my time.
Probably we have only 5 minutes for you to
Okay,
workshop.
that'll be very quick. So I'm going to really teach you this very fast. So progressive muscle relaxation is a wonderful technique that you can use wherever you are to relieve stress or tension. So as you breathe in, you tighten a group of muscles that I'm showing you with my fist. You tighten them, breathing in. And as you breathe out, you relax the same group of muscles. So if you can all do that with me. So breathe in, breathe out. You do this 3 to 5 times. I'm going to let you practice on your own. And you will notice the difference in sensation before you squeeze your hand and after you squeeze your hand. And it's with different parts of your body. And it's very, very effective in the short term. Next slide. What I want to show you now is something called the 4-7-8 breath. And this is what diaphragmatic breathing is. So the 4-7-8 is you breathe in for 4, you hold for 7, you breathe out for 8. And Dr. DK, if you can click on the little arrow there, this is what diaphragmatic breathing is. When you breathe in, you push your diaphragm down and your belly comes out, and you breathe out, you exhale deeply, pushing your diaphragm up. And when you do this in and out movement, you're strengthening that vagus nerve, which again strengthens the parasympathetic nervous system. And what I recommend, and I do this every day, 4 breaths in the morning, 4 breaths at night. And over time, you are going to become a calmer person and you will be able to control your stress. Believe me, this works. It's not going to happen in a week or 2 weeks or a few months, but over time, you will notice the difference. Next slide. And I'm going to leave you with this loving kindness meditation. So I'm going to ask you all to find a comfortable position in your seats. You may close your eyes or you may stay up in the distance. I'm going to ask you first to notice any tension in any part of your body and relax that portion. And then as I say these words, I want you to say them to yourself. May I know peace. May my heart remain open. May I see the beauty of my own true nature. May I be healed, and may I be a source of healing for others. I invite you to take a few breaths, breathing in and out. And as you breathe out any tension or stress. And now I invite you to think about someone you love or someone you feel who might need this in the moment, whether it's a relative, a family member, a friend, or the whole world, or peace in Ukraine. It doesn't matter. Pick a target and direct this to them. May you know peace. May your heart or hearts remain open. May you or you all see the beauty of your own true nature. And may you all be healed, and may you be a source of healing for others. Coming back to the breath, take a few breaths, and then you can gently open your eyes and come back to the room. Next slide. Thank you all for listening to me. I hope it wasn't too rushed, and I hope you got a few tips on how to relax. Thank you very much for this opportunity.
Thank you, Dr. Mascarenhas, for such a wonderful talk. Thank you for sharing your expertise with us and sharing those exercises. So we'll take questions at the end, and we'll move on to our third speaker. Our third speaker is Ms. Erin Lasnik. She's a registered dietitian and certified nutrition support specialist at the University of Pittsburgh. Ms. Lasnik has been a registered dietitian for over 10 years and holds a board certification in nutrition support, focusing on tube-fed patients with all disease states, including pancreatitis. She currently works with several pancreatologists and assists patients in the nutritional management of their disease course. Please join me in welcoming Ms. Lasnik, and I will share your screen, your slides, Ms. Lasnik.
Thank you. Nope, I'm not able to see my slides at the moment. There we go. So my name is Erin, and I was asked to do this talk to give you an idea of basically nutrition across the lifespan, because I believe that we do have both pediatric and adult patients going on here. So I wanted to cover basically all bases that I could. So next slide. So the objective is just quickly to give you an idea is to understand diet through the life of how it can affect our pancreatic health, and to potentially be able to learn how to make a few simple changes to improve our own diet and lifestyle choices in the context of pancreatic health. Next slide. So generally, to begin with children, adolescents, I didn't quite go back as far as infancy. While there are a lot of things that are discovered during infancy, I do respect that neonatal nutrition is definitely its own realm. So I chose to pick up a little bit more maybe from the toddler children realm here. So mostly, not all, however, most pancreatic conditions, of course, are not diet controlled or caused, or they're not diet caused or related. However, a healthy diet is still important. As Mackenzie referenced in her introduction here with her experience, she's chosen a much more holistic lifestyle, and therefore experiencing that healthy diet is important, and also how it has impacted her life and how it's been a positive impact in her life. Ultimately, as a dietitian, my role in patients is to do a nutrition assessment. So not only am I looking at objective measures like your height, your weight, if you've lost weight, if you've gained weight, lots of things that are lab measures, I also want to know what's going on as far as what you're eating, of course. So we'll do reviews as far as portions, cooking styles. We're going to want to know if we're doing takeout. If we are, what kind of choices are we making? And a lot of times people get a little, I think, intimidated. They go, oh, I have to talk to a dietitian. And so it's always important to just be honest with whatever you're eating, because then just remember that there is not any kind of criticism or judgment. We're simply here to help you. And if there's something that we don't know, then it is a little bit difficult for us, of course, to do our best job in helping you. I always joke with my patients that if you're going to eat some cake or something like that, that's fine. Just be honest about eating the cake. I have plenty of patients that like brownies and they still like to go for their occasional fried foods, especially now that we have Lent going on with fried fishes and things like that, and all the fish fries, I should say. So hey, everyone has their threshold, but ultimately we still want to try to lead as healthy of a lifestyle as we can. And always at the minimum try to go back to our portion controls. The one thing I like to point out is specifically in the children adolescent population is the low fat diet gets thrown out a lot, and it is certainly beneficial in a lot of ways. However, it is not necessarily shown, as many people would know through their care, to lower or directly affect lipase levels. That does not mean go gung ho, of course, and start eating everything under the sun that's heavy and fried. However, it does note that children and adolescents still need fat in their diets. There's brain development, there's organ development, there's eye development. There's so many things still going on. There's just caloric need for overall growth and development. And so ultimately, it's not so much a restriction as much as it is focusing on healthier fats or overall portion control. And but of course, still having our moderation in there too of some fun. As we've heard also in our last presentation, the different ways that we can be active, in particular yoga. Definitely not that necessarily is the only thing for children. I think it would definitely be great. I believe actually from some coworkers that have children that it's actually been incorporated into gym classes these days. So it's definitely becoming significantly more widespread. And whether your kid is more into things like sports that are a little bit more active, like football, soccer, softball, things like that. Nonetheless, being active can do a lot of things for our metabolism, a lot of positive things for our metabolism. So I think it's important to incorporate there. And I'm glad to hear that the thoroughness of how yoga is benefiting us actually, because it comes up a lot in my patient population. Next slide. So I like to say, what is well balanced? Honestly, as a dietitian, I feel like it gets thrown around a lot. So realistically, what does that mean? There isn't necessarily a definition of well balanced, because realistically it will change for patients depending on their different needs. Ultimately, what you're seeing there is my plate. Depending on how long some of us have been around, it's basically the newest version of the old pyramid of how we basically are supposed to portion our diets. So this basically divvies things up to about 25% each. We like to identify it as half about fruits and vegetables, 25% about grains, and 25% protein. The protein is on the lower end because most things do pack a punch once you have the right portion size. For the pancreatic population, though, we do have to be mindful of it because sometimes proteins can come very marbled with fat, which can be bothersome to people. The grain factor we like to generally keep on the 25% side, mainly to avoid having excess carb in the diet. So the one thing I like to focus on, the concept of well-balanced in patients, though, is the concept of a mixed meal and snack. So it's important that whether you're going to have a meal or a snack, that you're going to do it and have as many of your macronutrients at one time. So your macronutrients are basically things that contribute calories to your diet. These things are protein, fat, and carbohydrates. The things that you can turn over a package and see on the nutrition facts label, those ultimately all add up to what the calories are. It's best to have all of those at a meal because ultimately it's really optimal for digestion. If we eat just something like carbohydrates, it can really spike our blood sugars. If we eat all of those things as a mixed meal, it's much less likely to do that. And that goes for people whether they have pancreatitis issues, whether they're just a walking, talking, healthy otherwise person, it is still healthy for them to eat what is considered a mixed meal or a snack. Like I said, it's important to observe portion sizes. That's one of the best ways that you can kind of observe a well-balanced diet ultimately. One of the general recommendations for everyone across the board is to limit simple sugars. I myself still like to have a dessert, absolutely. However, we do have to keep in mind that every day is not necessarily a good moderation. Something more like every week is a little better. The one thing I like to point out too about this is I chose to show you the My Plate with an example of also kind of the rainbow there. giving fruits and vegetables, and just also ideas of what goes into these different categories. But the one thing I always like to note too is that normally there's a cup of milk, which there is up in there, but not everyone is a dairy person. That's there in order to promote calcium intake, which can be done through many other of those fruits and vegetables and other foods visible here. So just to note that you don't always have to take that in. Those of you that more prefer something like almond milk, oat milk, soy milk, any of the other substitutions are just fine. I actually would prefer if that cup was just water. And that is because a lot of people, unfortunately, are consuming other beverages, which is great. However, our body does still need just simple, plain old water sometimes. Next slide. So going into kind of the old adult/elderly, so realistically, maybe somewhere sitting around 25, 26 and up. Pancreatic issues may be affected by lifestyle and diet choices. That does not mean that everything you have taken in or everything you have done in your life is contributing to absolutely what has occurred to you. There are still many, many underlying factors. One of the physicians I primarily work under does extreme genetic research into this, so therefore I have seen what can ultimately be just for what is genetically underlying. So I don't want to scare anyone by thinking that if they ate too many fries or something like that, that they're going to have pancreatic issues. It just is shown ultimately through many, many studies and many, many reviews that over time, ultimately some of these habits can lead to some of these issues. In particular, the ones that I see most within my patients would be pancreatic cancer attributed to high-fat diets, highly processed meats. So if you're something like a salami eater, if you're heavily into processed deli meats that are over the counter and stuff like that, probably the biggest lifestyle one for that would be smoking. So I say these more for the adults, hopefully, because most of our children, if all of our children are not smoking and drinking, but ultimately, so that's why it's falling under this category. But then we do have our pancreatitis too, which I see most often with our high fat diets, our alcohol intake, and our smoking. The one thing I did want to bring up that I do believe is going to be discussed in more detail further on, and I bring this up mainly especially because it's actually hitting the public eye more than I realized. I was watching, I believe, something on Hulu the other day, and it was actually a commercial advertising exocrine pancreatic insufficiency. So physicians, be prepared for the public to maybe be coming in and bringing this up. But in a nutshell, it is an acquired loss of pancreatic function over time as an umbrella term there for various reasons. So in the context of diet, though, and why I bring this up is because people are most affected by fat intake. So whether you actually have something going on already diagnosed with your pancreas, or there is something maybe that needs to be diagnosed with your pancreas, the diet side that takes most prominence is the fact that people tend to usually start to notice their symptoms when they have a heavy fat meal. In particular, I always bring up a fried food meal because that tends to be the biggest trigger for people. However, there are still some healthy fats that can still be triggers for people. And by triggers, I mean most of these people are unfortunately having things like diarrhea. They have something called steatorrhea, where it's more of a fatty stool that they're having. They might have pain after a fatty meal. They might have feeling fullness. Maybe the meal wasn't very large, but it feels like they ate a very large meal. And so ultimately, if these people do get diagnosed, things like that down the road, depending on the illness and what they might find, a low-fat diet might be recommended for someone like this in order to offset unpleasant symptoms and also to hopefully not progress any further in what might be going on with them. Next slide. So just to give an idea what makes a low-fat diet, I chose to not give any ranges here because ultimately what is a low-fat diet is going to vary by person. So there are general recommendations out there. However, technically it's based on what your calorie needs are, and everyone's calorie needs are different. So ultimately I wanted to focus on if you ever were to need something like a low-fat or a controlled fat diet, you would have an idea of how to go about that. So you see the nutrition facts panel there, circled there in red is the total fat area. For, again, those of us that have been around, trans fats are not really seen as much these days. However, they do float around every once in a while. Saturated fat is still going strong, and that is still to this day the bad fat. So we don't want too much of an excess in there. It will occur naturally in some foods, especially in something like an animal product. However, when we see saturated fat, and there's a lot of it in something like a honey bun that we bought from a 7-Eleven, ultimately that is not going to be a good source of saturated fat. And I say a good source because at least in some cases it's coming from an animal. We get some other things from it. but it's certainly something we want to avoid in an over-the-counter product. I focus more on the mono unsaturated and polyunsaturated. Of course, we are clearly not in a chemistry class, so we're not going into why those are so good. But ultimately, if those are the higher amounts on your nutrition facts panel under total fat, that's your best way to go. So you're going to want to focus as you're shopping, maybe next time if you have the time, flip around a few of the packages on some things as you're shopping and start to familiarize yourself with what might be in some of your products. The other thing I like to focus more on in the concept of a low-fat diet is to focus on your cooking methods. So again, I say do not fry, and that's just because it is the biggest trigger. When I have patients unfortunately come back to the hospital or they're calling into the office, it's usually, what did you eat? And they tell us that they had, especially after this past weekend, fish fries. So it's usually something that's some sort of a fried item. However, I do have some patients that can tolerate it. So the best methods you could possibly do for yourself, though, and really anyone, regardless of any underlying issues, you can broil, you can roast, you can bake, you can eat things that are just fresh, like salads, things that don't require any cooking. If you are to use any oil, one of the best oils you can use is olive oil. There are some others, but to be completely honest, a lot of them are not the most economically friendly things in the world. Not that olive oil is either sometimes. I like to use olive oil also because in the event that you are to choose to fry something and trial it out, it's one of the better oils to actually fry in, and that's because it holds a better heat tolerance. So therefore, as you need to heat it up to fry it, it's better to use than some of the oils on the market. So a lot of times for patients that do trial it, that's the usually better oil they do with. On a side note to that too, on the cooking methods, I have had patients try the air fryers that are out there these days. That is definitely a patient-specific tolerance. I have had some people that are succeeding very well, and other patients who I think it was just maybe a little too early in some of their recovery to try that. But definitely something that is another approach that I think is worth it because ultimately it doesn't put a lot of fat on the food. It's an easy way to cook. And a lot of times, especially just anyone trying to follow any kind of diet these days, we need convenience. So if it's something that works out for you, it's definitely worth going for. Next slide. So just some quick take-home tips for you also. Children still need fat for growth and development. Avoid heavy limitations unless necessary. Focus on healthy types of fat. Avoid frying foods and limit alcohol and avoid smoking. Thank you all for allowing me to talk, and I look forward to your questions.
Thank you so much, Ms. Lasnik, for that great presentation. Sorry. I have to introduce the next speaker. And our next speaker is Dr. Brownell. He's an assistant professor of pediatrics, Division of Gastroenterology, Hepatology, and Nutrition, and the co-director of Pancreatic Disorders Program at the Children's Hospital of Philadelphia. He completed his medical school, residency, and chief residency at the Medical University of South Carolina in Charleston, South Carolina, and then a fellowship at CHOP. Both in medical school and fellowship, his first patients were children with chronic pancreatitis undergoing TPIAT. So while training in CHOP, he also completed fellowships in clinical nutrition and clinical pharmacology, focusing his clinical research on dietary fat malabsorption and exocrine pancreatic insufficiency. Since joining the pancreatic program at CHOP, he has overseen the significant expansion, nutrition, psychological, and procedural services, building a team that can meet the complex needs of patients with pancreatic disease. And he's going to talk to us about exocrine pancreatic insufficiency and the ins and outs of pancreatic enzyme replacement therapy. Thank you so much, Dr. Brownell, for joining us, and I'll share your slides.
All right, thank you, Dr. DK. You can go ahead and go to the second slide to start with. So I always think it's very important that you know who's talking to you. So I had a little slide here to introduce myself, but essentially I'm a big nerd who is known among the residents at our children's hospital for just constantly tying everything back to both poop and dietary fat malabsorption. I also was a line cook in a restaurant for 4 years, and so I can't go without comparing everything to food and putting everything in the context of food. I also joked I did too much training, but I think it ended up being the exact right amount for this very specific topic. Also a caregiver and a family member of someone with pancreatic disease. So have that perspective as well. So next slide. What we're going to do today is remind ourselves what the exocrine pancreas does. Everyone knows about the endocrine, but we've got to talk about the exocrine. That's the, as a gastroenterologist, the most important part. We're going to review how we know if it's not working and discuss how we treat exocrine insufficiency. Next slide, please. So going back to food, I always think of the exocrine pancreas like a bunch of grapes. In my mind, it just overlays on the pancreas very well. So the grapes themselves are the acinar cells. That's the part of the pancreas where the enzymes are made. You can advance a little bit, Dr. DK. And then the grapes come together at the stems, and the stems and the pancreas are the ducts that take all those enzymes into the small intestine. And so if we go to the next slide, the pancreatic juices have four main components. There's the enzymes that come from the grapes or the acinar cells, and then the ducts, which carry the enzymes to the intestine, but also make the pancreatic fluid, are made up of water, sodium, and bicarbonate. Go to the next slide, please. And so you have your enzymes that break food down, water that carries everything, flushes it into the intestines, and the bicarbonate neutralizes your stomach acid. Next slide. So these are the different types of enzymes that you have. Essentially, there's the proteases that break down the proteins in your diet. There's the amylases that break down the carbs in your diet, and then the lipases break down fats. So those are your three macronutrients, the three types of enzymes that break them down. And you can see that the proteases and the amylases make up about 95 to 98% of all of your enzymes, and lipases and the breakdown fats are a very small portion. Although it's weird because most of the rest of the time, and as you heard in the talk before, a lot of it comes back down to fat. But your pancreatic lipases are actually extremely efficient. Just about 100 milliliters, or a little over 3 ounces of pancreatic fluid has enough lipase in it to digest all of your fat intake for the entire day. So your pancreas is an incredibly efficient organ. So next slide, please. So if you lose all of this, what happens? Next slide. So if you lose your proteases, your stomach can actually make up for it a little bit. Your salivary glands can make up for not having the amylases. The problem is you can't make up for those incredibly efficient lipases that do all that job digesting fat. And so that's where the problem comes in. Next slide. So as Erin was mentioning, you can see commercials now for Identify EPI, which is a website that's put out by AbbVie, who makes one of the pancreatic enzymes, but causes a number of symptoms. So we heard about steatorrhea before. That's just the fancy medical term for fat in your stool. We have to make up terms to make ourselves feel superior to everybody. But you'll notice a lot of these are symptoms that are, can easily be written off to something else, like reflux or IBS, or maybe just eating the wrong thing, or lactose intolerance. So honestly, that's why AbbVie made this website, because exocrine pancreatic insufficiency is actually something that goes unnoticed for quite a while. Next slide. So those are the symptoms that you would be thinking about that might make you think you should ask your doctor about it. These are the sort of things that we think about on the other side. As a nutrition professional, and I see somebody who has pancreatic disease, I'm worried if their pancreas isn't working that they're not getting enough calories overall. And so that's why they're either losing weight, or if they're a child, they're not growing to be as tall as they should be. But then you have symptoms of not absorbing the vitamins that are dissolved in fat in your intestine. So those are the vitamins A, D, E, and K, which may sound familiar to some people. But if you're deficient in those, then you can have problems like easy bruising or nosebleeds that take a long time to stop, tingling in your hands and your feet. You can get vitamin B12 deficient and have anemia, or have some rare neurological problems. And then essential fatty acid deficiency can cause your hair to fall out, or your hair to be thin. Most of the time in kids, we notice that they just don't need a haircut for a year or so. Next slide, please. And so then the question is, what causes exocrine pancreatic insufficiency, or EPI? So there's kind of three big categories. Anything that decreases enzyme production. So people who have chronic pancreatitis or chronic inflammation of the pancreas, who may be told that they have an atrophic pancreas, or it looks small when they get an ultrasound or an MRI. It's smaller because you lose these acinar cells, and so you're not going to be making as many enzymes. When you're malnourished, your body kind of prioritizes things in a weird way, so it's not going to put much energy or resources towards making enzymes. Remember, they're incredibly efficient, so it really tries to back off and get as close as it can to making just enough. Then, of course, doctors always cause problems. We take out part of the pancreas. We can reduce the volume enough that you become excipient insufficient. Anything that keeps activated enzymes from reaching the intestine, so people who have a pancreatic duct obstruction from calcification, like in chronic pancreatitis, or people who have an IPMN or another cancer that's blocking it off, you get an excipient insufficiency just because the enzymes can't make it there. Enterokinase is the enzyme in the small intestine that activates all your pancreatic enzymes. Remember, they're not supposed to be activated until they make it to the small intestine, and when they're activated too early, that's what causes pancreatitis. And so any sort of inflammation in the intestine, like from celiac disease or Crohn's disease, can disrupt that enterokinase enzyme and prevent pancreatic enzymes from being activated. And then finally, anything that inactivates them too soon, the main thing there is too much stomach acid. So a lot of different ways that you can get pancreatic insufficiency. Next slide, please. And so then there's a huge problem here because we don't really have a clear criteria for what excipient pancreatic insufficiency is. We keep talking about reduced pancreatic function, but that's really as clear as the definition is. And in reality, pancreatic function is a spectrum. It's not just an off or an on sort of thing. Symptoms can pop up at different degrees of pancreatic function. So someone who's lost only a tiny bit of their pancreas, their tests are going to be normal. They may not really have any symptoms. And then a little bit later, when they've lost a little more volume, tests are still going to be normal, but they might start to have some of those symptoms. Remember, they're really non-specific, things like gassiness and maybe occasional looser stools. And then tests will start to pick it up over time. And then by the time tests actually pick it up, you have guaranteed symptoms, and you may, at least in the case of children, start to have growth failure and more permanent consequences. Next slide, please. So we diagnose it. There's indirect tests and direct tests. I won't get into it too deeply, but the indirect tests are mostly the poop tests that I'm sure people have asked you to do. They're all horribly inconvenient to do. Nobody likes to do them. All the indirect tests are less accurate, but easier on the patient, whereas the direct tests are more accurate, but tend to be more invasive, require you to be put to sleep. Unfortunately, the two best ones are the mixed triglyceride breath test, which is not available in the United States. And then the malabsorption blood test is one that we're working on that would replace any sort of poop test, but it's not quite ready for prime time yet. So next slide. So the way we treat it once we've diagnosed it essentially is with pancreatic enzyme replacement therapy, or PERT, has a couple other names here, but essentially all we're doing is we're giving you the enzymes that aren't there. There's 6 different brands that are approved by the FDA in 3 different forms, but there are a ton of others out there that are not regulated by the FDA. It's interesting, the FDA wasn't actually regulating them until 2010, so there are a lot of preparations that are out there. Unfortunately, that makes a lot of our data surrounding them a lot more confusing. Next slide, please. So these are the 3 different forms. So you have coated capsules, which are brand names Creon, Zenpep, Percy, Pancrease. These have a coating on them so that they can pass through the stomach without being activated, and then they don't start to become active until they get in the small intestine where the pH should be a little bit higher. But remember, we talked about before, bicarbonate is one of the things that the pancreas makes to neutralize stomach acid. And if it's not making that, then it takes a little bit longer for that for the stomach acid to be neutralized. And so they're not the most efficient things, but they're at least protected going through the acid of the stomach. The uncoated pill, Biocase, there's only one brand name of that, whereas the other ones are coated so they can get through the stomach. This one is not coated. So it starts working as soon as you pop it in. And so we very rarely ever let people actually consume this themselves, because it's full of things that digest protein and fat, and what are like your cheeks and your esophagus and your stomach. They're just bags of protein and fat and water. That's all we are as humans anyway. So they can be dangerous if not used correctly. And then cartridges for people who are on tube feeds. This little cartridge just goes in line between the bag and the person's stomach, and it gets digested as it passes over those little granules there. Next slide. And we dose these in 2 different ways. So either by the patient's weight, which is less precise, but is a lot easier for us to do based on how much somebody weighs. They're just going to estimate, like, you're this many pounds, you should have, 3 of Zenpep at each meal, 2 with snacks, just kind of based on, we know essentially what your fat intake is going to be, or we can kind of guess based on your body size. Then the much more precise way of doing it is based on how much fat you're taking in. Now you have to know a lot more about what's in your food. If the weight-based dosing doesn't seem to be working and people seem to have symptoms, then one of the things we can try is switching over to fat-based dosing. Next slide. So I have a sequence of slides here that just kind of show you how much fat can vary within your meal. And I'm not showing you this because I'm trying to get you to not consume fat. In fact, not consuming fat is not healthy because that's an important source of calories, and at least when you're a growing child, important source of building blocks for your brain. So this is just to show you the variability in a single meal of how many enzymes you might need. So for this one, just the spaghetti and the sauce, minimal fat, you just need 1 capsule. On the next slide, you see that we add butter, and that increases the amount of fat up to 2 capsules. On the next slide, we add just a couple of meatballs, increasing the fat some more. So then you need more capsules. And then, of course, it's America, so you have to put cheese on it. It'll go down easy if it's cheesy, but then you need more capsules. So you can see how just a single prescriptive dose that we might give based on this person's weight may not cover the meal entirely. Next slide. So then if you come into the clinic and you're still having symptoms, and we know you have EPI and we're trying to figure out the dosing, the things we'll be looking at in the short term are, are your stools still fatty? Do you still see oil in the toilet? Are you still having flatulence? Abdominal pain? How have those things changed? If you're an infant and you can't tell us those things, we look to see whether you're starting to regain the weight or regain your weight gain velocity that you didn't have before. In adults, we just want to make sure that you're not losing weight. And then, monitor you for essentially those fat-soluble vitamins, those sort of symptoms. Next slide, please. And then if we need to do some troubleshooting, then we're going to make sure that the timing of the enzymes is right, that they're not expired, of course. In addition to being denatured in acid, they get deactivated in sunlight. So the high schooler who's keeping them in the glove box and leaves them there while they park in the parking lot at high school and then go into school, like that'll deactivate them. Then, if your stomach acid is not being neutralized, if you have no pancreatic function left, sometimes we'll add either like an antacid along with it, or something like Pepsid or Prilosec, which we think might help, but we're not totally sure about that. And then we can also change the dose. There's a really wide dosing range for these medications, and honestly, there's very few side effects, and so sometimes you might be pushing the dose up a little bit. But then it's always important, as with any patient anywhere, to take a step back if they're not responding the way you think they are, to think about other things that could be going on. We've only touched on all the different things that can contribute to exocrine insufficiency. There's also all the other things that contribute to normal fat digestion in your gut. So like having the normal bile acids, have you had your gallbladder taken out? Are you on other medications that might affect it? There's so many different things that contribute. And so often we find ourselves stepping back and kind of going through that list and crossing things off. Next slide, please. So there is a question about whether these pancreatic enzymes can actually treat pain in people who have pancreatic disease, particularly pancreatitis. There is a little bit of evidence for this in animal studies where you put pancreatic enzymes into their small intestine, it decreases their pancreatic secretions, so it makes them less likely to have an episode of pancreatitis. The problem is in humans, this data is all over the place. When you look back and try to look at all the different studies that have been done, unfortunately, the patients are all totally different and have totally different diseases, different causes of pancreatitis. Remember I said that the enzymes weren't regulated by the FDA until 2010, so all the studies before then are using just various unregulated enzymes that you probably couldn't even get again today if you needed to. They're also looking at very inconsistent outcomes. So some are looking at whether pain improves, some are looking at quality of life, some are looking at nutritional status, and so it's really hard to kind of synthesize all that data together. But what is clear from those is, because they are inconsistent, is that some patients clearly do get better and do have an improvement in abdominal pain when they're taking enzymes. Next slide. Or yeah, perfect. So this is from a study that our group did actually, and this was actually in adult patients who have chronic pancreatitis, where we were trying to see, really tease out the effects of pancreatic enzymes on a number of symptoms, and we had them fill out 1 million questionnaires, which I'm sure that negatively impacted all their symptoms. But you see kind of 3 lines in each one of these symptoms. So a T-score means that's the average for like the 50th percentile, the average for the population. So anything above that means there's more of it. Anything below that means there's less of it. And you have 3 lines. The first line is people who don't have pancreatitis. Second line is people who have chronic pancreatitis but aren't on enzymes. And then the third line is people who are on enzymes, those same people after they've taken enzymes. And so curiously, you know, even though the pain, you see it, there's not really a statistical difference between this, you know, behaviors that are related to pain. Some little bit of a difference in pain intensity before and after enzymes, not really a difference in how pain is interfering with lives. But, you know, there was actually a study that just came out today, or in the last week, from the University of Cincinnati, looking at people who had pancreatic surgery, and they had really high rates of depression and anxiety afterwards. We'd all been focusing for so long on pain and whether they were taking opioids and all this. And so what's fascinating to me is in this, you know, at the time it wasn't as interesting, but now that I think about it, you know, we saw clear differences in anxiety and depression symptoms. And so, you know, maybe we're not nudging pain too much, but just by treating people's exocrine insufficiency, we seem to be making a difference in their anxiety and depression symptoms. Next slide, please. And so there actually are a couple of studies coming up, both in adults and pediatrics, really trying to tease out who the right people are to give enzymes to have that desired effect. So there's definitely more on the horizon shortly. Next slide. So I know I've been talking very quickly, but just to look over the objectives and make sure that I actually hit all the high points. We did talk about what the pancreas does. We talked about how to know if it's not working, what those symptoms are, how to test for it very briefly, discuss how it was treated, and how we can tell it's working, and some steps we can take to fix it. Next slide. This is my incredible group that I'm surrounded by, with psychologists, surgeons, dietitians, endocrinologists, researchers, radiologists, everybody. So I left you a couple of QR codes. The top one is information about our program. The middle one is actually a link to all of our educational website info about pancreatic enzymes, how to give them, what foods to pair them with if you're doing the fat-based thing, and all that information. And so I really thank you for your time, and I thank all of these people for making all this possible.
Thank you so much. Thank you so much, Dr. Brownell, for an excellent talk. So next we will invite our second patient speaker. I'm sorry. Our second patient speaker is Ms. Dee Whitehead. She's a retired banker, and she enjoys spending time with her lovely grandchildren now. She's a patient living with exocrine pancreatic insufficiency, and she will also share her story on the impact of eating a healthy diet on reducing flares of pancreatitis. It's an honor to welcome Ms. Dee, and thank you so much for joining us. I'll give it over to you.
Thank you so much. I really appreciate this opportunity. My story started probably in my early 30s. I noticed a definite difference in my health, mainly due to having to run to the bathroom constantly. I was diagnosed with irritable bowel syndrome with diarrhea. And with that diagnosis, it rather ruled my life for many, many years. My life surrounded pretty much always locating the first bathroom, no matter where I went. It was a lifestyle that was stressful, to say the least. It impacted my family life, my work life, family vacations. It really ruled how I lived my life. And during this time, I was often, when I would meet with physicians, I was told it was due to my diet, even though I felt like I ate a fairly healthy diet. I love to cook and bake, and I was raised eating properly. And so that's the lifestyle that I led. And sometimes well, not sometimes, definitely, obviously, with my Southern accent, I was born and raised in the South, but I lived in the Northern United States and in Western Canada for many years. So I experienced many types of lifestyle changes and the way people ate and cooked, and was exposed to many different types of cultures. And I adopted many healthy lifestyle changes, or I should say recipes, and a diet that was varied. And nothing ever seemed to really change, though. I still always had this terrible having to run to the bathroom all the time. And I was told many times it was probably due to my cooking, which was offensive because my family didn't have these problems. My mother also seemed to always have this problem all her life. She had ulcer surgeries, and I too was treated for ulcers. I never had surgery, but many times was treated for ulcers and all types of things related to that. I had one doctor tell me that I needed to eat more oatmeal. And I realized very quickly they just didn't even look at my file because I'm allergic to oatmeal. And on that same subject, it was actually my allergy doctor who encouraged me to seek out a third gastroenterologist who actually listened and was very suspicious. And it was actually the PA at that gastro office that I saw first that said, you know what, with your history, I think you may have EPI. And I said, well, what's that? And sure enough, that's what it turned out to be. So I was put on enzyme replacement therapy. I currently take 40,000 units of ZenPep. Originally, I was told to take it 6 times a day. Because my diet is what it is, I am able to reduce that amount to twice a day on most days. If I need to, I can take more, but that has been more than sufficient in my lifestyle that I now lead. My cooking has not really changed, interestingly enough. I still eat very healthy. I do eat more fresh fruits than I used to because now I can tolerate them. I still avoid sugar. I cannot digest sucrose. And I have chosen to just avoid that. I pretty much exclusively use stevia and erythritol in my baking. And I've been very satisfied by that. And I very thankfully can digest fructose, which puzzles many people and confounds many people as they try to understand EPI. My main focus is I like to be an advocate for never giving up as a patient in your search to find the answers. I'm 68 years old, and I feel like people my age that have been diagnosed seem rather hopeless at times. I would like to encourage people to take control of their life and embrace change, that your life can change. And I think it does cause depression in many people. I am very hopeful and I want to be a positive influence. I lead a very active lifestyle, thankful to the enzyme replacement therapy. I no longer have the terrible symptoms of constant diarrhea. I have gained 10 pounds that I desperately needed to gain, and I do exercise every day, and I practice yoga every day also as a relaxation technique after I work out. I very much enjoy physical activity. I now weigh 110 pounds. I no longer faint once a week, which was another symptom I was experiencing. For about a year, I was literally fainting once a week. So no more of that either, bumping my head and getting hurt. My family is ecstatic to see me this happy. And I welcome any questions. There's one of the things I did want to emphasize, there are so many supplements out there and people hawking cures for the buzzword gut health. It's ad nauseum, no pun intended, that they want to sell people something and people want to believe there's a simple cure. And it is truly, it needs to have a multifaceted approach of diet, exercise, and enzyme replacement therapy. And no, I know I'm just a patient, but I embrace all of those things because I know they are necessary for me to live the life that I want to lead. Unfortunately, I live in a rural area that has no access to a licensed registered dietitian. But I have done my own research, and yes, it has turned me into a true science nerd regarding nutrition. And I have told and shared with other people that Medicare will pay for consults with registered licensed dietitians, but I also caution them, and I want physicians to do so also too, that there are no limitations on people calling themselves health coaches or nutritionists, and people can be duped by multi-level marketing trying to sell them supplements and programs and diets. And I hate diet culture. People need to eat. They need to eat healthy, whole foods. So I embrace Mackenzie's lifestyle. I loved hearing from her. I loved hearing from the licensed dietitian and all the others on this call. And I welcome any questions. And I hope I haven't jumped around and wandered too much. But I want everyone to know in my heart that nutrition is so important in this, and so is exercise. It really takes a determination and a complete approach to thrive with this. And I am thriving. There is no doubt. I'm doing fabulous. And thank you so much again for having me.
Thank you so much, Ms. Whitehead. Thank you. I now invite all the panelists to get on live and show their faces so that we can take some of the questions. I know people have a lot of questions, and I'm sorry that we've gone over time, but I would say please give us a few more minutes to be able to answer some of the questions we have live. I want to remind everyone that the NPF has the NPF website has a lot of resources on diet and pancreatitis and pancreatic disorders, and they also even have a cookbook. So check that out if you don't know about that. So I'm going to start with the first few questions. This one I'm going to direct to Dr. Mascarenas. Is going to be the first panelist talking. The first question we have is in India, particularly in Tamil Nadu, eating bitter gourd may reduce the effects of diabetes. Is this true?
I am going to pass on that question only because I haven't seen any well done literature to support that. I've grown up in India, so I understand the effects of herbs and spices and fruits and vegetables. And I think, methi seeds have also been touted as good for your pancreas. But I'm going to say there's not enough evidence, at least from my review of the literature, to support that.
Okay, thank you so much. Thank you so much. The next question I'm going to direct to Ms. Latsnik and Dr. Brownell. Any of you can answer. Would you recommend sprinkling the pills? This is enzyme replacement therapy on your meal. 5 pills seems like a lot to take at once, or do you take them throughout the meal? Dr. Brownell, you can start first, and then Ms. Latsnik, you can follow through.
So yeah, there's one thing I didn't really get into is there are different strengths of them. So if you're, like with Creon, they're in multiples of 6. So if you're having to take like 5, 6,000 or 6,000 strength pills with every meal, there is a 36. So if that's what you are hopefully seeing us, like someone like Aaron and me, for, is so that we can do all the difficult math for you. There are actually a couple of drugs that are in trials right now, which would be just like a 1-pill enzyme that you would take with each meal. So hopefully that's not going to be a huge thing going forward. But Aaron, I don't know if you want to speak to which things you can sprinkle on and that sort of thing.
Yeah, so I actually have a ton of patients that have swallowing issues, so the capsule is just unrealistic for them. So we tend to utilize applesauce is usually the easiest, but unfortunately I do have some patients that don't do well with that texture either, so then we resort to something like pudding. So it really bases on their own texture. On the other perspective, I have patients with feeding tubes. I mean, luckily, hopefully nobody in this chat has a feeding tube, but if you do, that becomes a whole nother issue of trying to get the enzyme down a tube.
No, those are very great answers. I wanted to say the applesauce, we usually, even babies, that's how they dose their enzyme, is enough applesauce to cover the beets. Dr. Mascarenhas wants to say something.
I would say that whatever medium you put it in, the pH should be acidic, because then it enhances. If it's an alkaline medium, the enzymes don't work as well. And so when you open the capsule, the enzymes don't work as well as if you swallow them. That's the bottom line. So the way to do it would be to see a psychologist who can help you swallow them. They work very well with some of our patients who have a hard time swallowing pills. So be aware that that is a resource.
Great. So Dr. Mascarenhas, since I have you on, I'm going to ask you another question. What would you recommend for anyone that would like to go a more holistic direction for enzyme pills? Has there been any research regarding the usage of some spices such as turmeric to help with digestion?
India has lots of spices that help with digestion, lots of them, lots and lots and lots. And turmeric is a wonderful anti-inflammatory agent. But if your pancreas is not making enough enzymes, or if your pancreas cannot make any enzymes, there's nothing you have to give an exogenous form of enzymes. That's where it is right now. So while I would love to say you can use different things to help digest food, but they won't replace what enzymes do.
Great. Thank you. So Mackenzie, I'm going to ask you the next question. It's directed at you. How did you get started with your medication? So just summarize. I'm good with diet and being active, but medication is the biggest challenge fighting my chronic pancreatitis. What do you suggest?
Awesome. Yeah, I think this was from Alan. He asked, how did I get started with meditation? So meditation, transparently, is the first thing to go if I'm super busy. So I totally understand that. I definitely recommend sort of like a crawl, walk, run approach, just taking it lightly in the beginning, just a few minutes a day, I found to be extremely beneficial in the beginning. I also use an app called Insight Timer. It's free. They have a lot of guided courses. So you can do like a 30-day course of guided meditations, and it tracks how many days you've done in a row as well. So I also found that really helpful when trying to create a habit of meditating.
Thank you. So Dr. Brownell, you're next. What type of blood work would you suggest to test for malnutrition? Or how would you diagnose malnutrition in a patient who has chronic pancreatitis?
Yeah, so it's different in kids and adults. There's just different criteria for malnutrition. Usually it's based on your weight, your height, if you've lost weight, what your intake is. Unfortunately, there's not like a single blood test that's going to diagnose malnutrition as much as we all want there to be. We do look at tests for specific nutrient deficiencies, but there's not going to be one single test that gives you kind of global, calorie malnutrition. So it's kind of a combination of your story, how much you're eating, what you were like, a couple months ago, if you've lost weight, if you've maintained it, if you've gotten skinnier. And then some of those symptoms we talked about with nutritional deficiencies, and then some of the specific levels of those vitamins.
Thank you. Dr. Mascarenhas, you want to add anything to that?
No, I'm good.
Okay,
He
great.
answered it beautifully.
Okay, next question is for D. Whitehead. You talked about Medicare. It says Medicare will not allow a dietitian for my chronic pancreatitis, and I'm in Colorado, but I called and they refuse on them. I'm diabetic, which I will be if I don't eat correctly. Do you have any way or resources to help this patient get around this?
Now, you're going to need to repeat that first part. I wasn't quite sure what one of the words were.
So they said that Medicare, the insurance, Medicare will not allow them get registered dietitian for their chronic pancreatitis. You know how you said you were, working with with a registered dietitian is key. But her insurance will not allow her to get one, and she's in Colorado. Already, and they refused.
Traditionally, I believe your doctor has to go contact or have a recommendation for that for you. And that's probably going to involve a specialist as your gastro doctor, or if you're seeing an endocrinologist. And hopefully, if Medicare approves, your Medicare supplemental insurance may also kick in depending upon your carrier. Also, if you are in a hardship situation, you can appeal for a sliding scale approach with that practitioner. But my main caution would be make sure they are a registered licensed dietitian and not someone who says they are a expert and have a very dicey educational background. There are many diploma mills doing pseudo licensing, I call it, for health coaches that do nothing but take people's money. But I have never personally worked with a registered licensed dietitian. I wish that I had, because I know, doing my research, how invaluable that would be. I've had to educate myself, but not everyone will do that. It takes someone very determined and stubborn to be able to do that. And I qualify on all those counts. I am a very stubborn person, but I realize many people give up. They just are too discouraged and too worn down, especially if you've been diagnosed at a later in life, such as myself. People don't want to change, but we need to embrace it.
Thank you so much. Thank you for that contribution. I'm going to also allow the registered dietitian chip in. Ms. Lasnik, do you have something to add?
Yeah, so unfortunately with Medicare, that's something that's actually notorious in my field. If you can get your PCP or your GI doctor to write a referral for specifically medical nutrition therapy, that tends to be the terminology that Medicare likes to hear, regardless of diabetes or not. So that might be at least the next route they can go. Sometimes, sadly, it comes down to just literally wording of things. So that's usually what we have to do with medical nutrition therapy to get things covered.
Okay, and I'm going to take the last question about how to find a doctor who specializes in chronic pancreatitis. The NPF has resources. They have NPF centers of excellence. So I think turning to the NPF would be a good resource. I don't know if the NPF would also have resources of how to get around trying to get dietitian coverage. but it's something to check with them on. But I just want to thank our excellent speakers for such a wonderful and educative session. We've learned a lot from your expertise, and we've learned a lot from your sharing your stories for our patient speakers. And we've learned a lot from all the questions asked online. So please feel free to continue to turn to the NPF for resources on how to deal with your disease, and reach out if you have any questions. Thank you so much for joining us this evening, and have a wonderful evening. Thank you.
Thank you.
Thank you. Bye-bye.
Bye.